Good morning, and thank you for that kind introduction. It's a real pleasure to be with you today, and I'm going to be focusing on treatment updates for metastatic HER2 positive breast cancer today, changing paradigms. These are my disclosures. For several years now, we've had really a standard of care for the treatment of metastatic HER2 positive breast cancer. In the first line setting, we've been treating with the THP regimen in accordance with the Cleopatra study. This study was recently updated with almost 100 months of follow-up, with a median overall survival observed in favor of pertuzumab, 57.1 months versus 40.8 months. So that really became the first line standard of care. And then in terms of the second line, the EMILIA study really led to standard second line therapy. This was a study looking at T-DM1 versus capecitabine plus lapatinib, with an overall survival benefit 25.9 versus 29.9 months and a hazard ratio of 0.75. So we've really had a very consistent standard for first line treatment, second line treatment, but the third line and beyond or alternative strategies in either of those settings have been an unmet need. So it's been a really exciting couple of years for treating HER2 positive breast cancer because we've had a lot of really successful drug development in this space. We've seen novel tyrosine kinase inhibitors, the advent of antibody drug conjugates, and re-engineered HER2 monoclonal antibodies, and we'll focus on each of those topics today. We'll first start with oral HER2-directed tyrosine kinase inhibitors, specifically Neratinib and Tucatinib, which were both FDA approved in 2020. So we'll start with Neratinib and look back at the phase 3 NALA study of Neratinib for HER2 positive metastatic breast cancer. As you'll recall, women with HER2 positive metastatic breast cancer who had had at least 2 prior lines of HER2-directed therapy were randomized 1-to-1 to receive Neratinib with capecitabine plus loperamide for diarrhea prophylaxis versus lapatinib versus capecitabine, and 621 patients were enrolled in this study. The co-primary endpoints for the study were progression-free survival and overall survival. And I'll just remind you of a few baseline characteristics. About 17% of patients had brain metastases. 70% had 2 prior HER2-directed lines of therapy. About a third of patients had had all 3 of trastuzumab, pertuzumab, and T-DM1, whereas 40% of patients had received prior trastuzumab alone. And this was the centrally confirmed progression-free survival analysis as presented last year in 2019, 2 years ago now, 6.6 versus 8.8 months in favor of the Neratinib combination. And that led to the FDA approval of Neratinib in February of 2020 for patients with HER2 positive metastatic breast cancer after 2 lines of anti-HER2 directed therapy. And in fact, in referencing the most recent NCCN guidelines from January 15th, 2021, this is given a category 2A recommendation. Now, what was presented at San Antonio this past year, the 2020 San Antonio meeting, was an interrogation of a subset. So specifically patients with brain metastasis. So brain indicated as location of disease at the time of enrollment. So 51 patients receiving Neratinib met that criteria, whereas 50% of patients who were randomized to the lapatinib arm met that criterion. And Dr. Sora presented the results from that analysis. And here's a summary of those results. Specifically, progression-free survival, not statistically significant, but favored the Neratinib combination, 5.5 months versus 7.8 months progression-free survival. Pretty similar overall survival, 15.4, 16.4 months that was not statistically significant. And in looking at CNS progression-free survival specifically, there was a trend to benefit in favor of Neratinib, 8.3 versus 12.4 months, but with a p-value that was not significant and a hazard ratio that extended beyond 1. So potentially there's a role for Neratinib for CNS metastases specifically. And what was also interesting about this presentation was that patients with leptomeningeal disease were enrolled in the study. In fact, 3 patients with leptomeningeal disease were enrolled. 2 were treated on the Neratinib arm and 1 patient was treated on the lapatinib arm. In the Neratinib arm, the progression-free survival for these two patients with leptomeningeal disease was 5.6 and 9.8 months. And as you'll recall, the progression-free survival for the brain mets population was 7.8 months. So this is in accordance with the overall CNS intention to treat analysis. And the overall survival for these two patients was 17.4 and 19.8 months. And again, the overall survival for the brain mets cohort was 16.4 months. So this is in alignment, which is encouraging because this is typically a very poor prognosis population. In the Lopatinib arm, the progression-free survival was 4.3 months and overall survival was 6.5 months. So these are very small numbers, but these data do complement what was observed in a TBCRC study, which also enrolled 3 patients with leptomeningeal disease and were treated with Neratinib. And they saw 2 patients who had an overall response rate out of the 3 enrolled. So these are very small numbers, but leptomeningeal disease remains an area of unmet need. And it's encouraging to think that there might be a role for a tyrosine kinase in the treatment of that typically poor prognosis population. Now I want to pivot away from HER2 positive just for a moment and focus on a new category potentially of disease, which is the HER2 mutant population of breast cancer. So HER2 mutations occur in about 2% of primary breast cancers and 7 to 8% of hormone receptor positive metastatic breast cancers, and have a unique mechanism of oncogenic addiction to HER2 signaling. And in fact, acquired HER2 mutations may confer resistance to endocrine-based therapies. So the SUMMIT trial was a large basket trial that looked at various combinations, including Trastuzumab, Neratinib, and fulvestrant in a cohort of patients with HER2 mutant, but HER2 negative by standard definitions, hormone receptor positive metastatic breast cancer. And it's notable that it included patients who had previously received either fulvestrant, so 71% had previously received fulvestrant, and 59% had received a prior CDK4/6 inhibitor. And here's the swimmer's plot from that presentation. Komal Javari presented at the San Antonio 2020 meeting this data. She reported an overall response rate of 45.9% in this HER2 mutant hormone receptor positive population, with a duration of response of 10.9 months and a median progression-free survival of 8.3 months. So interesting data, and I have to say I've used this combination in a handful of patients with HER2 mutant hormone receptor positive breast cancer and have had anecdotally some success with this regimen. So I think it's an encouraging regimen for potentially a novel definition of patients, namely those with HER2 mutations. Now, going back to our HER2 positive population, another tyrosine kinase inhibitor was approved last year for the treatment of HER2 positive metastatic breast cancer based on the phase 2 HER2 CLIMB trial. This is a study in which 612 patients were randomized 2-to-1 to receive tucatinib, a tyrosine kinase inhibitor, together with capecitabine and trastuzumab versus placebo with capecitabine and trastuzumab. I'll just summarize some of the key patient characteristics. All patients had received prior trastuzumab, pertuzumab, and T-DM1 for the eligibility criteria. The median prior lines of therapy was 3 with a range of 1 to 14. The distribution of hormone receptor status is outlined here. 60% had hormone receptor positive disease, 40% hormone receptor negative disease, and those are in red because we're going to focus in on those subsets today, as well as the brain metastasis population, 48%. And as you'll recall, active brain metastasis were permitted on this study as long as they didn't require local therapy. 60% had treated brain metastasis, 22% untreated, and 18% progressive but not requiring imminent local therapy. And here are the results: progression-free survival and overall response rate from the original San Antonio 2019 presentation in the New England Journal of Medicine publication in 2020. Median progression-free survival in favor of tucatinib, 7.8 versus 5.6 months with a hazard ratio of 0.54. And a notable improvement in overall response rate, namely 41% versus 23% for the control arm. And here is the overall survival analysis. Median overall survival 21.9 versus 17.4 months. And it was ultimately this data that led to the FDA approval of tucatinib in April of 2020 for HER2-positive metastatic breast cancer after at least one line of HER2-directed therapy. So what was presented at the most recent San Antonio meeting in a presentation by Dr. Erica Hamilton was responses by hormone receptor status. And here you can see when broken down by hormone receptor positive versus negative, the overall response rate was numerically higher in the tucatinib arm regardless of hormone receptor status. So specifically, objective response rate was 27% versus 37.4% for hormone receptor positive. And the magnitude of benefit was even greater for the hormone receptor negative with response rate of 15.6% versus 45.3%. And in looking what kind of responses were generated, well, there were very few complete responses in either arm. However, most of the responses were stable disease, about half of patients achieving stable disease if they had hormone receptor positive disease, and about 41% for those who had hormone receptor negative disease. And in terms of partial responses, 36.9 for the tucatinib arm and 43.8 for the tucatinib arm in the hormone receptor positive and negative populations, respectively. So Dr. Hamilton also presented progression-free survival Kaplan-Meier curves by hormone receptor status. On the left, you see hormone receptor positive subgroup with a hazard ratio of 0.58. The progression-free survival in that group was 5.6 versus 7.6 months in favor of the tucatinib arm. And then looking at the right at the hormone receptor negative subgroup, the hazard ratio was 0.54 with the median progression-free survival 4.2 versus 8.1 months in favor of the tucatinib arm. What about overall survival? So here the Kaplan-Meiers by subgroup again. On the left, you have the hormone receptor positive subgroup with a hazard ratio of 0.85, not statistically significant, but a difference in overall survival, 18.2 versus 21.7, so a potential trend in favor of tucatinib that was not statistically significant. And on the right, for the hormone receptor negative subgroup, there was a hazard ratio of 0.5 with a p-value of 0.003 with a median overall survival of 14.1 versus 31.1 months in favor of tucatinib. So there was a clinically meaningful improvement in overall survival in patients receiving tucatinib, regardless of hormone receptor status. What about patients with baseline brain metastasis? So that subgroup of patients who is allowed to enroll as long as they didn't require local therapy for their brain metastasis. So again, this subset is broken down by hormone receptor positive versus negative. We're getting into smaller and smaller numbers as we look at smaller and smaller subsets. But in this case, you also see that there was a progression-free survival benefit favoring the tucatinib arm in patients with brain metastasis, regardless of hormone receptor status. And as you'll recall, Nancy Lin presented data regarding CNS benefits in patients with brain metastasis at the ASCO 2020 meeting. And at that time, she reported a 68% reduction in death, in risk of CNS progression or death in that population, and a 42% reduction in risk of death specifically. So what about when we look at these analyses by hormone receptor status? And that's what Dr. Hamilton presented at this recent San Antonio meeting. Here you see overall survival in patient with baseline brain metastasis by hormone receptor status. And here you see overall survival was numerically improved in patients with brain metastasis in the tucatinib arm in both hormone receptor subgroups. Notably, the hazard ratio for the hormone receptor negative subgroup was 0.37, indicating a more than 60% reduction in risk of death in favor of tucatinib. So very exciting to see innovation in the setting of HER2-positive breast cancer brain metastasis, which historically has been an area of unmet need. So moving on now to HER2-directed antibody drug conjugates. We're going to focus on two antibody drug conjugates, one which was recently FDA approved. And that was Trastuzumab Deruxtecan that was evaluated in the DESTINY-Breast01 study. That was an open label phase 2 study of Trastuzumab Deruxtecan in HER2-positive metastatic breast cancer, looking at various doses. And in this part 2, the 5.4 milligram per kilogram dose. Primary endpoint was confirmed overall response rate, and there were a number of secondary endpoints. Notably, patients had to have HER2-positive metastatic breast cancer. They had to have received prior T-DM1, and patients with stable treated brain metastasis were allowed. Here are some baseline characteristics that I just wanted to highlight today. Median age was 55. Per the eligibility criteria, all patients had received prior Trastuzumab and T-DM1. 66% of patients had received prior pertuzumab, and 54% of patients had received other prior HER2-directed therapies. Notably, the median prior lines of therapy for metastatic disease was 6, with a large range, but this is obviously a very heavily pretreated population. Almost all patients had visceral disease, so high burden of disease, and approximately 30% had a history of brain metastasis. Again, patients with brain metastasis were allowed to enroll as long as they were treated and asymptomatic. And here's the waterfall plot that was presented in San Antonio 2019 and in the New England Journal of Medicine publication in 2020. Very impressive 60.9% overall response rate in this very heavily pretreated population. And then looking back at the progression-free survival and overall survival data that was initially presented after 11.1 months of follow-up, median 16.4 months progression-free survival. Overall survival at the time of the initial presentation had not yet been reached. But notably, the median progression-free survival in the 24 patients with brain metastasis was 18.1 months at the time of that presentation. Now, at the recent San Antonio 2020 meeting, Dr. Shinu Modi presented an update from this study with a median follow-up of 20.5 months now, with an overall response rate of 61.4%. The median progression-free survival was 19.4 months, and although cross-study comparisons are discouraged, it's worth reminding ourselves that the Cleopatra THP regimen in the first-line setting conferred a progression-free survival benefit of 18.7 months, just for context, in comparing this heavily pretreated population. The median overall survival at this presentation was 24.6 months, but only 35% of events were captured. So here's the head-to-head comparison of the initial presentation with the August 2019 data cutoff versus the most recent San Antonio presentation with the June 2020 cutoff. So almost double the amount of median follow-up, encouraging that the overall response rate is maintained, initially presented as 60.9% and more recently presented as 61.4%. No significant differences in the type of responses observed, but highlighted in red below, you'll see the duration of response initially reported as 14.8 months was more recently reported at 20.8 months, and the progression-free survival slightly improved, 16.4 versus 19.4 months. So encouraging to see that not only were responses and duration of responses retained, but were actually improved when looking at duration and progression-free survival specifically. And I've also highlighted the time to response here, 1.6 months. I think that's one of the notable features of this drug, especially if you have a patient who's pending, say, a visceral crisis, to know that you can achieve a response for your patient in such a short period of time, I think is incredibly encouraging. Now, what if we look at responses by number of prior lines of therapy? And you can see here the confirmed overall response rate by line of prior therapy, second, third, fourth, fifth, and sixth. And you can see that responses were observed regardless of prior lines of therapy, including in the very heavily pretreated patients with more than or equal to 6 prior lines of therapy. Also, when looking at subgroups, and so this is objective response rate with the bar there at 60%, there were no differences in overall response rate by any of the subgroups that were interrogated. What about toxicity? Well, this is the toxicity data that was initially presented. Nausea is very common on study with mostly grade 1 or 2 events. Fatigue, alopecia, vomiting, constipation and neutropenia being other notable side effects. Very few grade 3 side effects, and notably prophylactic antiemetics were not mandated in this study, but are likely to be incorporated in future studies. One of the most notable side effects from the initial reports of Trastuzumab Deruxtecan was an AE of special interest, namely interstitial lung disease. So in the initial presentation, 4 grade 5 events, so fatal events of interstitial lung disease were noted. The sponsors had appointed an adjudication committee to look at the cases of potential or confirmed interstitial lung disease, and notably among the 25 events that occurred overall, the median time to investigator reported onset was 193 days, but there was a large range, 42 to 535 days, indicating that vigilance throughout treatment is really critically important. 17 of 20 patients with grade 2 or more interstitial lung disease received steroids, and we'll go through the algorithm in a moment, but all patients with grade 2 or more interstitial lung disease should receive corticosteroids. 7 patients recovered, 2 were recovering, and 12 were either outcome unknown or not followed until resolution. And as previously noted, 4 patients had died. Of the 4 fatal cases, onset was 63 to 148 days. So again, a huge range from initiation of treatment to death. 3 of those 4 patients received steroids, and death occurred 9 to 60 days after diagnosis. So close monitoring is recommended for patients receiving this medication, and the initiation of steroids as soon as interstitial lung disease is suspected is recommended. So as part of Dr. Modi's presentation at the San Antonio meeting, we did see an update on the incidence of interstitial lung disease. There was 1 additional grade 5 case reported, so 5 cases of interstitial lung disease. But in looking at the cumulative probability of adjudicated drug-related ILD in the curve below, you'll see that ILD appears lower after approximately 12 months on treatment, suggesting perhaps that the risk of developing ILD is not related to a cumulative dose of Trastuzumab Deruxtecan, although continued monitoring and attention throughout administration is critically important. And algorithms have been developed. For patients with grade 2 or more interstitial lung disease, the drug should be permanently discontinued and steroids initiated. For grade 1, that's asymptomatic interstitial lung disease, so apparent radiographic finding without symptoms, the drug should be held. Steroids may be considered, and if resolved, one may consider initiation or reinitiation of drug at a dose reduction. I just want to highlight one other study looking at Trastuzumab Deruxtecan that was presented at the San Antonio meeting. This is a study that combined the medication with nivolumab. This is based on preclinical studies indicating that the combination would be incredibly synergistic, and some phase 1 data of nivolumab with Trastuzumab Deruxtecan in HER2 positive and HER2 low breast cancer and urothelial cancer. So in this study, the 2 medications were interrogated at 2 different doses of Trastuzumab Deruxtecan, 3.2 and 5.4 milligrams per kilogram, together with flat dose nivolumab. And one of the cohorts had HER2 positive breast cancer after T-DM1, and another cohort had HER2 low breast cancer. And those 2 cohorts were described at this recent meeting, and you can see the combination generated encouraging waterfall plots for both the HER2 positive and the HER2 low cohorts. Notably, the HER2 positive cohort had received a median 5 prior lines of therapy, so again, a very heavily pretreated population, and the HER2 low cohort having received 4 prior lines of therapy. I want to mention a couple other ongoing studies. There are a number of ongoing DESTINY studies looking at Trastuzumab Deruxtecan in various settings. I just want to highlight a couple here. This one I think could be a potential game changer. This one is looking at Trastuzumab Deruxtecan versus T-DM1 in the 2nd line setting. So again, T-DM1 based on EMILIA has become a standard of care. And so Trastuzumab Deruxtecan will be challenging that standard of care, and results are anticipated in 2021, and that could be a potential game changer in terms of clinical practice. It's also worth noting the DESTINY-Breast04 study. This is a study that's ongoing in HER2 low metastatic breast cancer and could also be game changing, as well as redefining a subset of patients based on HER2 low status. I just wanted to touch on another HER2-directed antibody drug conjugate. This was not data that was presented at San Antonio. However, it's worth noting that studies are ongoing. It's a HER2-directed antibody with the same amino acid sequence as trastuzumab. The active toxin alkylates DNA, killing dividing and non-dividing cells, and also, like other antibody drug conjugates, has a bystander killing effect. And in a phase 1 study, you can see the waterfall plot on the left below there with an overall response rate of 33%. So encouraging responses with this antibody drug conjugate. It was generally well tolerated. The primary reason for discontinuation of the study medication on this study was ocular toxicity in the form of conjunctivitis, dry eye, and increased lacrimation. Ophthalmology support for patients receiving this medication is probably beneficial. I just want to advise you that there is an ongoing study, the TULIP trial, looking at this drug versus physician's choice chemotherapy combinations with HER2-directed therapy in patients with advanced HER2-positive breast cancer. And finally, I'd like to conclude with a re-engineered HER2-positive monoclonal antibody that was just recently approved by the FDA. That's margetuximab, based on the results of the SOPHIA study. So this was a study looking at physician's choice chemotherapy. Physicians had a choice of capecitabine, eribulin, gemcitabine, or vinorelbine, together with trastuzumab or margetuximab in patients with HER2-positive advanced breast cancer. There were 2 co-primary endpoints, progression-free survival and overall survival. Results were presented at San Antonio 2019 by Dr. Hope Rugo, with results actually reported only a couple of weeks ago in JAMA Oncology. So we've seen these results on a couple occasions. There was the first investigator-assessed progression-free survival analysis based on the October 28 cutoff with a 30% risk reduction of disease progression, and then a subsequent second analysis at a September 2019 cutoff with a similar 29% risk reduction of disease progression. Specifically, the difference in progression-free survival was 44.4 months versus 5.7 months in favor of margetuximab. And in terms of overall survival, the overall survival difference in the initial analysis was a median difference of 1.7 months, not statistically significant, nor was it statistically significant in the more recent update with the September 2019 cutoff. But further overall survival analyses are expected later in 2021. And again, this is another drug that has been recently FDA approved for the treatment of advanced HER2-directed therapy. So we've had numerous FDA approvals of HER2-directed therapies in the metastatic setting in the last year and a half, which is incredibly exciting. And so how do we sequence these regimens for the treatment of advanced HER2-positive disease? Well, I would argue that based on the Cleopatra data, a taxane plus trastuzumab and pertuzumab remains a standard first-line approach. However, there are options now in the second-line setting. T-DM1 remains an option based on the EMILIA data. It will be determined from the T-DM1 versus Trastuzumab Deruxtecan study, which is anticipated to be reported later this year, whether that is still a standard second-line approach, but at the moment it is, as is tucatinib with capecitabine and trastuzumab per the HER2-CLIMB study that was just recently approved in this setting. In the third line and beyond, Trastuzumab Deruxtecan is approved in this setting. It's very active. It can overcome HER2 heterogeneity because of this bystander effect. Neratinib and capecitabine was also recently approved and may have some CNS activity, particularly in patients with leptomeningeal disease. And there are a number of other regimens that are currently approved in the NCCN guidelines for the treatment of HER2 positive disease, but I think it's incredibly exciting to see several recent FDA approvals in this space as innovation remains needed. Looking forward, what are the opportunities ahead? Well, not only are these drugs that we've talked about today being evaluated in different combinations, but there are other tyrosine kinase inhibitors, including Neratinib, which is an irreversible dual pan-HER2 receptor tyrosine kinase that shows very promising activity. Combinations with checkpoint inhibitors, so I showed you a combination with nivolumab today, but other combination studies with other checkpoint blockade molecules are ongoing. There are a number of studies looking at the role of CDK4/6 inhibitors together with HER2-directed therapies, as well as PI3 kinase inhibitors. So I think it's a period of tremendous excitement for treatment of HER2-positive breast cancer, with a number of exciting developments, with some really interesting recent updates at the San Antonio 2020 meeting. And I look forward to further innovation in the years to come. Thank you for your time.